Genital Herpes Masterclass. From pathogenesis to patient empowerment, everything you need to know. Core concepts. Start with the basics. The viral culprits, HSV-1, traditionally causes cold sores, but now accounts for 50% of new genital infections thanks oral sex. HSV-2, classic genital herpes, more likely to recur and to shed silently. Where they hide, HSV-1, latent in trigeminal ganglia. HSV-2, latent in sacral ganglia. Both lie dormant in nerves and reactivate under stress. How it spreads: skin to skin or mucosal contact, sex, oral, anal, genital, even hand to genital. Most transmission when there are no symptoms. HSV-2, asymptomatic shedding 10 to 20% of days. HSV-1, 2%. Risk factors: no condom use, multiple partners, immunosuppression e.g. HIV, coexisting STIs. What's happening under the skin? Pathophysiology. 1. Primary infection, incubation, 2 to 12 days after exposure. Virus replicates in epithelial cells, triggers local inflammation. Lesions form when cells die, equal vesicles and ulcers. HSV evades detection by downregulating MHC-INE, dodging CD8 plus T-cell response. Recurrent infection, triggered by stress, UV exposure, menstruation, illness, or trauma. Virus travels from ganglia to skin via neurons. Lesions are usually smaller, more localized, and heal faster than the first time. What it looks like. Clinical presentations. A. Primary genital herpes. Classic sequence: painful vesicles, ulceration, crusts, last 2 to 4 weeks untreated. Systemic symptoms: fever, body aches, painful lymph nodes. Atypical cases: herpetic proctitis, MSM, rectal pain, bleeding, tenesmus. HSV urethritis mimics chlamydia, dysurious discharge. B. Recurrent genital herpes, prodrome, tingling, itching, or shooting pain at the site, 12 to 24 hours pre-lesion. Lesions: small, shallow, grouped vesicles or ulcers, usually on one side, heals in 5 to 10 days. Often missed. Subclinical shedding equals tiny fissures or microulcers. C. Special populations: immunocompromised, HIV transplant, cancer patients. Chronic deep necrotic ulcers, higher risk of acyclovir-resistant HSV due to thymidine kinase mutations. Neonatal herpes, transmission during vaginal delivery, 3 forms. 1. CM, skin, eyes, mouth lesions. 2. CNS, seizures, lethargy, poor feeding. 3. Disseminated, liver failure, de-ice, pneumonia. Mortality up to 80% if untreated. Treat aggressively with IV acyclovir x 21 days, CNS disseminated. How to diagnose? Testing that matters. PCR, polymerase chain reaction, gold standard, sensitivity 95%, used for active lesions, especially vesicles. Technique: unroofed vesicle, swab base firmly. 2. Serologic testing, type-specific IgG, detects prior exposure. HSV-2, almost always genital. HSV-1, can't distinguish oral versus genital. Antibodies develop in 2 to 12 week testing pitfalls. PCR false negatives, late-stage crusts or healed lesions. False positives, IgG, especially if HSV-2 index equals 1.1 to 3.0, confirm with Western blot. Treatment: control, suppress, prevent. First clinical episode: valacyclovir 1 gram twice daily, x 7 to 10 days, or acyclovir 400 milligrams tide. Reduces healing time, pain, and shedding, but does not prevent latency, recurrent infections. 1. Episodic therapy. At prodrome onset, valacyclovir 500 mg med x 3 days can cut healing from 4 days. 2. Suppressive therapy, so 6 recurrences a year. Valacyclovir 500 mg once daily, recurrences by 70 to 80%, transmission risk to partner by 48%. Complicated or severe disease, hospitalized, treat with IV acyclovir 5 to 10 mg kilo-QH. Use for disseminated HSV, hepatitis or pneumonitis, neonatal disease. Acyclovir-resistant cases, often in immunocompromised, use Foscarnet I 40 mg kilo-Q8. Don't miss these. Red flags and mimic. Syphilis, painless ulcer, always check RPR-VDR, chancroid, painful deep ulcers plus tender nodes, EBV-CMV ulcers, in immunosuppressed, do PCR. HSV-HIV synergy, HSV enhances HIV replication. Suppressive therapy can reduce genital HIV RNA, but ART doesn't fully suppress HSV. Patient counseling essentials, empathy education, the truth about recurrence. HSV2 may recur 4 to 6 times a year, especially early on. HSV1 tends to recur far less frequently in the genital area. Transmission facts. Condoms reduce transmission by 30%. Daily suppressive antivirals can cut transmission risk nearly in half. Normalizing and destigmatizing. Most people with herpes don't know they have it. You are not alone. This is one of the most common STIs worldwide. Lifestyle tips. Keep the area clean and dry during outbreaks. Avoid touching lesions, then touching eyes. Avoid sex during prodrome or lesions. Need to know stats. Metric detail. HSV2 prevalence, 12% of adults. HSV1 genital, 40 to 50% of new genital herpes in younger adults. Asymptomatic shedding accounts for 70% of transmissions. Neonatal HSV, 1 in 3,000 births, up to 80% fatal untreated. Suppressive valacyclovir reduces transmission by 48% in couples. The bottom line, genital herpes is a lifelong companion, but it can be managed, controlled, and lived with fully. Use PCR to diagnose, use antivirals to treat, use empathy to educate, use knowledge to empower your patients. Whether it presents with angry ulcers or invisible shedding, you're now prepared to diagnose, counsel, and care with confidence. Would you